So just to outline that again, if you have a uterus, you're going to require estrogen and a progestogen or progesterone, and that's called combined HRT. And if you don't have a uterus, then you'll have estrogen only HRT. You don't need the progesterone, except if potentially if you've had a history of endometriosis, because if there's any parts left behind, then there is the possibility that they could grow, and that we don't want that to happen. So in some cases we might give a progestogen. So sometimes that progesterone will be body identical progesterone in the form of utrogesterone capsules, or it'll be a synthetic progestogen. And like I said, if you've had a hysterectomy, then you only need the estrogen part. If you're postmenopausal, then so you've got 12 months consecutively without any bleeds, then we would consider you in the postmenopausal phase, and you can have continuous HRT. So that's estrogen and progestogen every single day, all the time. If you're in the perimenopausal phase, so if you're having any degree of bleeding, and sometimes that can be really erratic and it's very difficult to keep track of them, then we would still consider that to be in the perimenopausal phase. And so we'd give you what we call a sequential HRT, or you might be referred to as cyclical HRT. And that's because the timing of the estrogen part and the estrogen and the progesterone part will sort of mimic the natural menstrual cycle. So you'll have 2 weeks of estrogen only HRT, and then you'll have 2 weeks where you have the estrogen and the progestogen combined together in whatever form you take your HRT, and then you'll go back to the estrogen only part. And when you do that, that's when you'll have a bleed. If you're having vaginal symptoms only, and it's often unusual for that to happen. I've certainly spoken to patients who think they've only got vaginal symptoms, but it's really been a lack of understanding of what the other symptoms might be that they've been experiencing, or they've been putting them down to lots of other things. But if you've only got vaginal symptoms, then you can just use topical or local estrogen therapy. So that's vaginal estrogen, or you can add that into systemic HRT, so the transdermal options or the oral HRT. And if you're getting genitourinary symptoms and physical and psychological symptoms of menopause, then we would certainly suggest that you start with systemic HRT, and often those will help the genitourinary symptoms and not require a separate vaginal estrogen. But if it does, it's not a problem, and you can add that safely in addition to the systemic HRT, because it's not actually adding to your systemic hormone replacement load, because it's just staying locally in the vaginal area. So are there women that can't have HRT? And there are actually very few women that are absolutely contraindicated to HRT. Current or active breast cancer would be one of them. So if you have a current diagnosis for hormone-sensitive breast cancer, or for women with a history of breast cancer, particularly estrogen receptor positive cancer, HRT is generally avoided, but it may be considered in very rare cases under specialist supervision. So that's not complete contraindication if the symptoms were significantly affecting your life. But if you've got active or current breast cancer, then that would be a contraindication. If you have undiagnosed vaginal bleeding of any sort, then it's really important that we just investigate that first to find out what's causing that and to rule out anything suspicious before starting you on HRT. So we don't want to leave that untreated or ignore that. So that's really important that we deal with that first. So we wouldn't put a woman on HRT if they had abnormal vaginal bleeding that had not been looked into. If you had, so endometrial hyperplasia, like I said before, is the thickening of the endometrial lining, and that needs to be treated if that was happening prior to being on HRT. If you have an active or a recent thromboembolic event, so a blood clot to the leg, for example, or to the lungs that is being treated, or then you wouldn't be able to start HRT at that time. Or if you've had a recent heart attack, stroke, or angina, we're talking about chest pains. Untreated high blood pressure is a reason to not completely avoid HRT, but it's just to say that we don't want to leave these things untreated and want to make sure we're taking care of women's all of their health needs. And so if we find something like that during a consultation when we're beginning HRT, then we would say, well, let's just deal with that and let's get that stable, and then let's begin the HRT. And so it's not really a definite no, it's more about saying let's deal with that as well. And we need to do these two things separately. And also active liver disease. HRT, particularly oral forms, are metabolized in the liver and should be therefore avoided until the liver function normalizes. So that would be a good reason as well. There are some times when we would use HRT with caution, so they're not absolute contraindications, but we want to be thinking about, like I said, making sure your blood pressure is controlled. We want to think about patients who have a history of migraine with aura. It's not a contraindication, but it's something we want to be aware of, so we're making the best choice of HRT to suit you. Like I said, if you have a history of certain types of cancers. If you've had endometriosis, estrogen-only HRT has the possibility of reactivating symptoms, so we would give it a continuous combined HRT might be preferred, even if they've had a hysterectomy, so we want to be thinking about that. And also if women come who have a high BMI, and we know that weight gain is such a big issue around menopause because of the change in adiposity, which is regardless of the nutrition and the workouts that you're doing, that you're probably seeing shifting changes in your metabolism and also where you distribute weight in your body. And so if you have a high BMI over 30, then you're at increased risk of blood clots. And so that's why we would say you absolutely can have HRT, but it would be the transdermal route, which we prefer to use with everyone anyway. And then we're going to ask about history as well, because it's really important to take a full history so that we know the pros and cons, and you can understand those risks as well associated with the type and the different choices around HRT options. Now, I did talk briefly about vaginal preparations before, and to say that this has been a really evolving area of information and knowledge, and it's really important for women who for a long time have not taught very much about genitourinary symptoms of menopause. It can be embarrassing sometimes. It's just not something we've wanted to share with people all the time, but can be absolutely debilitating in terms of women being able to hold down jobs or relationships, be able to wear the clothes that they want to, and be able to do the activities that they want to. The genitourinary symptoms of menopause describe a collection of symptoms around physical changes affecting the vulva, the vagina, the bladder, and the urethra due to estrogen deficiency after as estrogen levels start to decline. And it can result in things like vaginal dryness, itching, burning, pain during sex, vaginal irritation or discharge, recurrent or new urinary tract infections, having to go to the toilet more, sometimes having urinary leakage. And these symptoms, unfortunately, often worsen over time, and they require treatment to resolve. So please don't hesitate to come and speak to your healthcare professional if these symptoms are bothering you. Now, vaginal estrogen is local or topical, so you might hear any of those words associated with that. It's designed to be delivered small and targeted doses of estrogen directly to the vaginal and lower urinary tract tissues where it's most needed, so it restores the tissue integrity and function with minimal systemic absorption. So it's barely, if any, going through into the bloodstream. It reestablishes the thickness and the elasticity of the vaginal epithelium. It helps it increase lubrication naturally, restore pH changes, and that ultimately can result in changes in the type of bacteria lining those areas, and that's why we see changes in urinary frequency, but also UTIs and thrush. So hopefully we're going to reduce the instances of these and improve the health of the urethral and the bladder tissues. As you can see there, there's a variety of different types, and that's sort of the theme of the talk this evening, that there's lots of different options out there. There's creams, such as the estriol, which is the one at the bottom there. You've also got vaginal gels like the Bussel. You've got pessaries, although they're really vaginal tablets in the form of the Vagifem or the Vagirux you might be familiar with. You can get a ring, or a string it's called, which is an estradiol releasing ring, which lasts up to 90 days, and you can replace that. And you can use these things. I would really actually encourage you to use these things alongside other vaginal options, such as moisturizers, vaginal moisturizers, which are designed specifically so you don't have to put them on every day, like facial and skin moisturizers, but should last about 2 or 3 days, but use them as you need to. Lubricants, vaginal lubricants that you use just before intercourse, and also pelvic floor physiotherapy has a significant role to play in improving vaginal health as well during perimenopause and menopause.